Dear colleagues, in partnership with the Société Francophone de Nephrologie, Dialyse et Transplantation, the Deutsche Gesellschaft für Nephrologie, and the Österreichische Gesellschaft für Nephrologie, Marcus at Hope welcomes Dr. Dominique Bertrand in Rouen, France, in order to discuss the use of imlifidase in highly sensitized kidney transplant candidates. Before, we would love to touch upon some general differences in kidney transplant medicine between France and Germany. Dear Dominique, it's a pleasure to host you for the first stage of our Tour Académique 2025. And as we did in 23 and 24, we plan again to follow the Tour de France together with Dominique Guerrot. While the cyclists will have their Grand Départ Saturday in Lille, we are somewhat ahead and meet you virtually in Rouen, which is the destination of stage number 4 on Tuesday, which will start in Amiens and bring the tour to beautiful Normandy. So thanks again for joining us tonight.
Thank you so much.
I'm very happy to introduce you to Dominique Bertrand. Dominique is working in Rouen nephrology department. He's an expert in kidney transplantation and especially in the field of very sensitized patients. So he'll give an important talk on this topic. And for this discussion, we have two co-moderators with us. Matthias Girndt, who is a professor of nephrology and head of the nephrology and rheumatology department at Halle University Hospital and professor at Martin Luther University. His expertise includes chronic kidney disease and autoimmune kidney disorders, and Nicole Helmbold, who is the General Secretary of the Deutsche Gesellschaft für Nephrologie. So, Dominique Bertrand, it's your turn to speak.
Thank you so much. So it's a real pleasure to be there to discuss with you about the use of imlifidase. But the topic is mainly highly sensitized patients. Highly sensitized and the access to transplantation for this kind of patients. So we have to begin with the basics and to define what is a sensitized patient. Usually, patients are considered sensitized when they have at least one anti-HLA antibody. So it results from previous exposure, such as transfusion, pregnancies, or prior transplantation. And in this occasion, they could develop HLA antibodies. So this is the definition of sensitized patients. We have to notice that some anti-HLA antibodies target specifically a potential donor. In this case, we can talk about DSA, about donor-specific antibodies, and their presence significantly increases the immunological risk of transplantation with the risk of antibody-mediated rejection. So now we have to define the highly sensitized patient. And we can define the highly sensitized patient with the calculated panel reactivity antibodies. This is an estimation of the proportion of the deceased donor population against which the candidate has anti-HLA antibodies. So this deceased donor population can be different between countries. And as you can see, this is different between Eurotransplant, UNOS in the United States, and in France with the Agence of la Biomedicine. But in France, when the CPRA is higher than 85%, the patient is considered as highly sensitized patient. And the access to transplantation is not so good. And in that way, the French system has accept the acceptable mismatch program. What is the acceptable mismatch program? As you know, when you are highly sensitized patient, every 3 months you have blood tests, and we follow the anti-HLA antibodies. So the allocation of the kidney in that case is based on the extension of the patient's own HLA type. We create an extended HLA phenotype, and in that way, patients have more chance to get a transplant with this program. So this is the panel of the kidney transplantation in 2023, and as you can see, the part of waitlisted patient, highly sensitized waitlisted patient is high and is about 20%. And every year there is new listed patient and there is an accumulation in the wait list of highly sensitized patient with a low number of transplantation in this range of CPRA. So we made a study with colleagues from the Spicer group across 13 French centers of transplantation. This is a real-world study to investigate the access to transplantation according to the CPRA. And as you can see, the most impacted class of CPRA is when the patient is higher than 88%. And with this range of CPRA, the access of transplantation is lower than the other one, even when you are highly sensitized patient. But with the acceptable mismatch program, some patients have a good access to transplantation. But when the CPRA is too much, it's too high, the access is quite bad. Access is one thing, but we have to demonstrate that the patient on the waiting list could dare. As you can see in this slide, the mortality in this kind of patient is high and is higher than the other group when the CPRA is higher than 99%, as you can see here in the graphic. So this is an important point. The access to transplantation for highly sensitized patient, very highly sensitized patient in our allocation system is not good. And the mortality of this kind of patient is higher than the other group. So we have to do better for this kind of patient. So actually, this is the approach in France for the highly sensitized patient. This is always a stepwise approach. Initially, when we list this kind of patient, we wait for at least 3 years on the allocation system and with the acceptable mismatch program. But when the 3 years are passed and the CPRA is higher than 88%, we have to analyze the last blood test, the last serum, to know if there is a decrease or a disappearance of anti-HLA antibodies. And if there is a decrease of those kind of antibodies and a decrease of the CPRA, the most recent CPRA, we can consider kidney transplantation with historical donor-specific antibodies or very low DSA at date of the transplantation. But unfortunately, for some patients, there is a persistence of this kind of antibodies. And in this case of persistence of antibodies, we have to consider an active desensitization. So to make active desensitization, we need 4 tools. 4 tools to make a categorization of the risk to keep for this patient. First, this is the Luminex. The Luminex to detect the anti-HLA antibodies. Secondly, we have the flow crossmatch, the flow cytometry crossmatch, where it is very sensitive, but not very specific. And we have the CDC crossmatch, the cytotoxic crossmatch, which is very important to know the risk we can take for this patient. And lastly, we have the dilution. because some patients are very sensitized. But when you make a dilution in this kind of patient and you make a Luminex test, you can see that the sensitization could be different between the patient. So this is a risk stratification. And when a patient have DSA, the flow cross-match is positive and the CDC cross-match is positive, you take the higher risk for this kind of patient. What does it mean? It means that you take a risk, an immunological risk for antibodies-mediated rejection. And you can see here, when the CDC cross-match is positive, the risk of ABMR is about 50%. So this is the first thing, the risk of ABMR after kidney transplantation. And the second risk is the risk of mortality. Because if you are CDC positive, flow cross-match positive, and DSA positive, you can see here that the risk of mortality after kidney transplantation is higher than the other group. So we have to make active desensitization for some patients, but we have to make it with very caution. Okay, so we talk about this approach. So now we have to understand and to know how we can make a desensitization for this kind of patient. So we can make desensitization before kidney transplantation, on the day of transplantation, or after kidney transplantation. Historically, the use of IVIG was made with the team of Stanley Jordan in the United States of America and with Denis Glotz in France, with quite good results. But at that time, we had not Luminex, so it's quite different from today. Then they add rituximab to IVIG to improve the desensitization, and then the plasmapheresis. Now, the method we use, we can use the anti-EL6 for desensitization, and recently the anti-plasma cells like daratumumab or isatuximab could be used. And there are some studies in progress, like the use of belatacept. On the day of transplantation, you can use now from a short period Imlifidase, and we now talk about this treatment. So what is Imlifidase? As you know, Imlifidase is an enzyme from Streptococcus that cleave the IgG and then became inactive. So after an infusion of 20 minutes, you can see in this graph that the concentration of IgG will drop drastically in few hours to 0. And this for 3 to 7 days. And the problem is that after 3 to 7 days, IgG become to increase again. So this is the effect on immunoglobulin. But what we need is the effect on anti-HLA antibodies and on DSA. And when you look at the results of HLA antibodies, you can notice that before treatment, the intensity of antibodies are very high. And after 6 hours after treatment, you can see the blue bars very low. So after 6 hours, there is no more antibodies, no more DSA. And that's right also for complement binding HLA antibodies that can convert the cross-match from positive to negative. But the problem is, after 3 to 7 days, you can see the rise of the MFI, of the intensity of the DSA here in this graph. The results of the first study are quite Good. Here is the last study published with a cohort of 40 patients transplanted with imlifidase. As you can see, with a CPR rate very high, and this is donor in 80%. As you can notice, ABMR is frequent, about 40%, but the 3 years patient survival and graft survival are very good. This is the very recently published result at 5 years, and at 5 years, the eGFR is stable and quite good. And the immunodominant DSA and the intensity of the DSA are low at 5 years and lower than at the beginning of the transplantation. So we have 3 key messages from the phase 1 and 2 studies. First, the conversion of baseline positive crossmatch to negative was achieved in about 80%. Antibody-mediated rejection occurred in 39% of patients transplanted with imlifidase. But despite the high rate of rejection, the 5-year graft survival is good in this kind of patients. So in that way, with some colleagues, we tried to make some recommendation or guidelines of the use of imlifidase for the French nephrologist. So this is the recommendation we try to write. And first, this is the requirement for selecting a patient. So as we talked about initially, we have to have a patient with a CPRA higher than 88%, age below 65 years old, time on the waiting list at least 3 years, and the transplant unit have to have an access to plasmapheresis 7 days a week. Then we make the delisting of HLA antibodies that we allow only HLA antibodies with an MFI not exceeding 5,000 after a 1 in 10 dilution. At time of organ offer, we have to have at least 1 DSA and at least 1 DSA with an MFI higher than 6,000 of MFI. We have a pre-imlifidase virtual positive crossmatch on recent serum. We don't make a cell crossmatch at that time. And we have to get a negative crossmatch, a CDC crossmatch negative 4 to 6 hours after imlifidase infusion. We have to notice that the immunosuppressive regimen is very important after kidney transplantation with imlifidase because we can't use no EGG-based treatment in the first day after imlifidase because imlifidase could cleave this kind of treatment. We published the first 9 kidney transplants recently in Kidney International report with good results at short term. And to finish, I will just give you the French experience to date. So to date, 30 transplantation were made with imlifidase in France. The patient characteristics are here: very young patient, very long time on dialysis. And you can see that the CPRA after the delisting drop drastically from 89% to 65% after the delisting. This is the use of the immunosuppressive therapy after kidney transplantation with imlifidase. This is the DSA before imlifidase use, and as you can notice, there are very high DSA before the use of imlifidase with 20,000 when you check about the sum of the DSA. All the patients have a cross-match converted from positive to negative, and mainly from flow cross-match positive to flow cross-match negative. The follow-up is now about 10 months after kidney transplantation for 30 patients. There were no graft lost, and only one patient died at month 1 from a septic shock. This is the evolution of DSA after transplantation, and you can notice there is a rebound in a very high number of patients. And as we can see in the first study, there is a high rate of kidney rejection after transplantation with imlifidase. But when there is no rebound, there is no rejection. So this is very important after kidney transplantation with imlifidase. This is the rate of subclinical rejection with protocolar biopsy. And once again, there is a high rate of rejection. But the evolution was good. As you check the serum creatinine at 10 months, at the last follow-up, the creatinine was quite good in this patient. The infection rate was quite low, but there were no severe infection after kidney transplantation in this population. So this is the conclusion on the first experience of imlifidase in France in very highly selected population. As you can notice, we can notice also a rebound in 80% of patients. The graft function was quite good at the last follow-up. The conversion was possible in all the patients, and as we noticed in the first clinical use of imlifidase, there is a high rate of antibody-mediated rejection, but with an excellent short-term survival and an acceptable safety. So thank you very much for your attention. Thank you to all my colleagues who participate to the elaboration of the French guidelines. And I will be very happy to discuss the use of imlifidase with you.
Well, thank you very much, Dominique. This was an outstanding presentation, and thanks for sharing the French experience on this topic and the guidelines you co-chaired. So I would suggest first start with Matthias Girndt. Do you have some specific remarks to share on this topic and questions for Dominique?
Yeah, thank you very much. First of all, congratulations to this brilliant data, and I'm very surprised to see such good effects of the treatment in these patients. We discussed whether patients from our center could be enrolled in a Eurotransplant guided study in Germany, because it's not that easy to do such studies for regulatory aspects in Germany. And we looked at our patients on our waiting list and found 5 patients who fulfilled the criteria for treatment with imlifidase, but none of these patients seemed to be suitable because of age and other risk factors. So we did not enroll one of these patients. Maybe we were too scary to enroll patients because we feared the risks of infection. Infection was not a major problem in your series, was it?
No, it was not. But you know, I think we have to remember that the risk is the risk of desensitization, and not the risk only from imlifidase. We have studied that if you make an active desensitization, the rate of infection is higher than other patients. Yeah. But here, the first data, Yes, are quite satisfying. Yeah, I think.
Yeah, and how do I have to imagine the procedure? The patient gets an offer from your transplant organization, and then you have to find out, well, you know that there is a positive crossmatch before that, and you give imlifidase, you wait for 6 hours, and then you check the CDC crossmatch.
Yeah, that's perfectly right. And we have to be a little bit hurry because of the cold ischemia time.
Yeah.
We have 4 to 6 hours more than another transplantation. So before the acceptance, we know that the virtual crossmatch is positive. And we want a virtual crossmatch positive with at least 1 DSA and at least 6,000 MFI to predict a flow positive crossmatch. Then we make the infusion of imlifidase, that is about 20 minutes, and we wait for 4 hours. And then we collect another serum and we test for the CDC crossmatch. And if the CDC crossmatch is negative, we go to transplantation.
And it was negative in all your patients.
Yes, that's right.
So the efficacy of this substance is amazing.
Yeah, but we have to notice that we only perform 4 kidney transplantation with a CDC crossmatch positive before imlifidase. All other transplantation were CDC negative and flow crossmatch positive before the infusion of imlifidase.
I see. So the risk of these patients was a little bit lower.
That's right.
Also, those 4 with a positive CDC before desensitization went fine.
Yeah, that's right. Yeah.
So
all presented an ABMR and a rebound, but we can manage the rejection. And today, kidney function is good. So I think it's possible, but the risk is probably higher.
Yeah. And after transplantation, you probably checked the antibodies. And when they increased again, what did you do? There was no way to give imlifidase a second time.
Yeah,
that's right.
That's right. That's perfectly right. So as you know, imlifidase probably is only for one treatment. So you can use initially 2 infusions to negative the crossmatch.
Yeah.
But after that, you can't use because there is a sensitization to imlifidase and patients have antibodies against the treatment. So we check HLA antibodies after kidney transplantation, and we don't do nothing only for a rebound, because you have some patients with rebound without ABMR. So when we notice a rebound, we make a kidney biopsy. And if there are not ABMR on the biopsy, we didn't change the treatment.
And those with ABMR, they were treated by plasmapheresis or only by steroids? And
so all receive plasmapheresis.
Yeah.
Some receive rituximab, and 7 patients over 10 receive eculizumab.
Yeah. Okay, so it seems to be fine to do that. Well, what happened to the patients to the immunity of these patients? They were probably vaccinated against some diseases and they received imlifidase, so all their antibodies were gone. Isn't that scary to eliminate all these antibodies, or do they recover soon?
Yeah, it's a good question. Yeah, between during the 7 first days, they have no IgG. That's right. They are vaccinated, but during those days, they are not protected. So during the first days, they have antibiotics, prophylactic, and there are studies that check about the immunity after 7 to 10 days about IgG against some specific bacteria or virus, and they increase again. So this is a good point for those kind of patients. But we have to be very cautious for the first week. At day 7 in the French protocol, they receive an IVIG infusion. So after that is probably better.
Would you now, with your experience, proceed to treat also elderly patients with this treatment? You had an average age of, I think it was 48 years, which is quite young from a German perspective. Would you treat a 60-year-old patient or even elder?
Yeah, so you know, this is the first experience, so we have to be very cautious. So there are young patients waiting for a very long time on dialysis. But now we have patients, we fix a limit to 65 years old. And we are thinking about to put this limit to 70 years old. So I think when this is a balance, because if you have a CPRA at 100%, you can get a transplant. So on the other side, there is a risk, but we have to talk with the patient. We have to imagine the risk to be clear and to take a conclusion together with the patient.
Yeah. Great. Once again, thank you very much for this great data and this experience you shared with us. Maybe Gunnar Heine has more questions, or will we turn over to Nicole Helmbold to discuss general aspects of the transplant system in France?
Thank you very much.
I would actually have 2 questions. So thanks again. This was great. And thanks for these beautiful slides, which really helped us, particularly me as a non-transplant nephrologist for the time being, to understand this very difficult topic, actually. So the first question would be, and this also goes somewhat to transplant politics, but do you do the cross-matching at each center in France? So does each medical university have its own center for doing these studies, or do the vials first go to Paris or some central lab?
No. There is a central lab in Paris for all the Paris center, but in each university hospital for kidney transplantation, there is a lab for HLA and for the Crossmatch.
And the medication is available to all French transplant centers, so this can be done from Brest to Toulouse. Because reading your paper, I found that the majority of people who received the medication actually came from Toulouse, surely because there's a nephrologist whom we also hosted here twice or 3 times, who's very active in the field, but this is actually open to all French centers who do transplantation.
That's right.
Right. Yeah.
That's right. But you know, at the beginning, we talk about with Matthias, when you begin to make desensitization, you are scared from the infection complication, scared by the rejection, and at the beginning it's very difficult. So every center could use it, but now it's not the case.
And one last question from me to both Dominique's actually and also to Matthias. Do you also see a place for this medication in people who did not receive the medication on day 0, but who develop later on an antibody-mediated rejection? It might also work here. I've seen a small but very smart randomized trial from Berlin and Vienna. They saw a nice immunological response, but actually no clinical benefit, which was done by Fabian Halle and Georg Böhmich. So might there also be a place later in the, say, first year after transplantation?
You're right. There is a randomized trial for the use of imlifidase in the context of ABMR, but I don't think this is the better use of this treatment, because the most important of imlifidase is the very important place at the beginning of transplantation. Because if you perform a transplantation with DSA, with very high DSA, the DSA will go on the endothelium, and this is a very risky situation. And for some patients, plasmapheresis is not sufficient. So I think this is very important at the beginning of transplantation. And after that, if the patient did not have an ABMR, there is a kind of accommodation. So this is a very important place for this treatment at the beginning of transplantation. And at time of ABMR, if you propose the treatment to this kind of patient, after 7 days, there will be a rise of antibody. So in the context of a BMR, it's not totally the same situation.
I totally agree. It might be very difficult later on after transplantation to find the right moment to interact with imlifidase, because if you see the rejection, if you see the creatinine rising, it's already late. The antibodies have done their damage, and to treat with imlifidase might not be sufficient after that time. So I guess it's much better to have this antibody in the first place before transplantation, but I'm not so convinced that this will be possible later on.
Particularly as you have only one shot, huh?
Yeah.
Before handing on to Nicole, Dominique, trying to put this into an international perspective, do you know when you did the conference paper in 2023 and since then, has there been an international consensus on how to deal with this specific topic or not? How do the things change between how we deal with it in France with our specific ecosystem and financial perspectives, and in other countries, especially in Europe? Do you have any perspective on this?
Yeah, this is an interesting point, because France was very active in that field, in the use of imlifidase, but this is not the problem of imlifidase. It is the access to transplantation for highly sensitized patients. So the guideline, the recommendation is on imlifidase, but is more of the access to transplantation for highly sensitized patients. So after these guidelines of recommendation, some other country made also recommendation. The British Society of Transplantation, Spain, and Eurotransplant, with the Belgian Society of Transplantation. This is very European for the moment. So I think it's a good step for patients.
Okay, thanks. And Nicole, do you have some comments or questions on how the French and German perspectives change, are different from the other?
Yes, of course. Yeah, in Germany, we have been discussing now for several years to implement new legislative procedures to increase the number of organ donations. Because, for example, last year we had only around 1,400 renal transplantations, and over 30% of them were living organ donations. So, and I read that the numbers in France are much better. So you have, I think, about 30 postmortal donations per 1 million inhabitants. We only have 11. So what or why do you think you have much better numbers of organ donations than we have?
This is a very good question. Another topic, but a very nice question. And, you know, we have a good number of transplantation, but in France, the problem is the living donation. Because if you check the results, we only have 15% of the kidney transplantation performed with a living donor kidney transplantation. So this is our problem in France. But when you check about the deceased donor transplantation, the rate is better than yours, but this is also a problem in France. The opposition rate from the donor is very high, actually, and we try to improve this rate. But because we have 10,000 active listed patients, and we perform 3,500 kidney transplantation every year, and this number is very stable. So we have the same problem in France, but not in the same, proportion.
Yeah, but I think your post-mortal donations are 3 times more than ours.
Yeah.
And I've seen you have an opt-out system, and you have a centralized organization via your l'Agence de la Biomédecine.
That's right.
So, and we have an opt-in system up to now, and we are more decentralized. So do you think this makes a change to have more post-mortal? Or how does the l'Agence de la Biomédecine work? What exactly does they do to increase the numbers?
Yeah. This is important, but if you take a period of 10 years, there is a little increase of kidney transplantation, and it did not come from deceased donor. It come from DCD donor and not DBD donor. Okay, so from cardiac deaths and not from brain deaths. If you take a period of 10 years, and the l'Agence de la Biomédecine work very hardly on this topic. So cardiac death, living donation, but the rate of deceased donor very slightly progress. So it's higher than in Germany, but is not sufficient in France. But the fact to have the l'Agence de la Biomédecine, very centralized organization, it's very important, I think.
Which is your median or mean waiting time for people who do not have living donors? So we in Germany, we are now up to, I guess, Matthias, Nicole, 8 years, 9 years, something like that. I
the
guess
average is 10.
You are far lower than that, aren't you?
So what is the median time in Germany, sorry?
8 years, 9 years, something like that.
Are you sure? It's very high.
It depends on blood group. So there are blood groups having a waiting time average of 5 to 6 years, and there are other blood groups that really have 8, 9, and even 10 years of waiting time.
Okay, but in France it's about 2 years.
We are far from that, yeah.
Yeah, but I think it's I can understand that you have 50% of living donor kidney transplantation. So I think that the system of deceased donor, it's probably could be I think better. But I understand that I know that you are not in Eurotransplant, and this could be this can be changed in over the years or not.
In fact, yeah, we are members of Eurotransplant, but the rules are slightly different in the member states of Eurotransplant.
Okay.
So since we have so low donor rates, the Germans also have low transplant rates. It would be not very fair to our partners in Eurotransplant to take their grafts for our people.
But how can you explain that you have a high rate of living donation and a very low rate of deceased donor?
Yeah, first of all, we don't have the non-heart beating donors. This is prohibited in Germany.
Okay.
This is one thing to be discussed, but society is very reluctant to discuss that. And on the other hand, we have low rates of donation with some 50% rejection rates when there is brain death. And our procurement organization struggled very much to find all the donors in the hospitals, and they improved the process of finding these donors. It's still a process that is ongoing, but the major problem is that people don't agree with being a donor in Germany.
Okay.
And maybe it's part of the problem is that we have this opt-in rule, which separates us from our neighbors.
Yeah, I have no more questions.
Maybe one final question on health politics. So how does your system work? Are all kidneys from deceased donors given via a centralized system? So, or do you also have some regional programs so that people who die in a hospital in Normandy donate their organ to people on the waiting list in Rouen or in Le Havre or Caen?
Okay.
Or does it all go via Paris?
Yeah, I understand. So there is no regional politics, but if you have a donor, there is 2 kidney. So if we have a donor in Rouen, 1 kidney remain in Rouen. So Rouen or the region of Rouen, and the other one go in the national repartition.
And that you have an enticement actually. All right. Yeah.
Yeah, and this is the rules in all the country.
Yeah. Thank you. So this was a tough topic, and now we switch over to a very nice topic. So we would like to end this webinar, as we have done the last years, with some impressions of our host cities, which again, surely tonight is Rouen and Normandy. Dominique.
Yeah, so as you can see, I am very lucky to work with such a great clinician and friend as Dominique. I'm also very lucky and happy to live in Rouen. So where is Rouen? Rouen is in Normandy, as we have already said. So this is 120 kilometers northwest from Paris on the river Seine. So this is a photo from Rouen, and you can see the Seine here, this beautiful river. And the nice part of Rouen is here on the on the right side of the picture. So what can you see in Rouen? Well, the most famous building in Rouen is the cathedral. The cathedral is very, very beautiful. Gunnar, you know that very well. And it's been drawn by, painted by Claude Monet, who's done several paintings of this cathedral. This is at the Musée d'Orsay in Paris. You can see these paintings. If you come to visit Rouen in the summer, you can see some very interesting lightnings of the cathedral at night. So this is a very spectacular thing to see if you are in Normandy in the summer. I'd highly recommend you to see this. Very nice. It lasts about 20 minutes and it happens 3 or 4 times every evening. But Rouen is also a beautiful city, a very old city with very nice streets you can walk through. This is, I think, the most interesting thing to do in Rouen is really to discover this ancient city. Here you can see what we call the Gros Horloge. You can see this clock in the middle of a nice street going from the cathedral to the Place du Vieux Marché. And if you go into this building, this is what you can see. You can see the cathedral at the end here, and this is a typical street in Rouen. Another typical street. This is the Rue Haut de Robec, where you have some water running here, and you can go through this old street and have a glass on the terrace. There are also some funny houses, some funny old houses in Rouen. You can see this house, which is slightly bending. When I arrived in Rouen a few years ago, I was a bit worried about this house, but actually it remains as it is since quite a long time. So you can visit this near one of the numerous churches in Rouen, l'Église Saint-Maclou, which is really a beautiful place. And if there's one historical thing to remember from Rouen, it could be this one. It's Joan of the Arc, Jeanne d'Arc, who was in the 15th century a young French woman who led the resistance against the English during the 100 year, la Guerre de Cent Ans. And Joan of the Arc was caught and given to the English in Rouen, and she had a trial for heresy, and then she was kept in this dungeon where you can visit a museum of Joan of the Arc's history. This is just next to the main railway station in Rouen, and Joan of the Arc was burnt for heresy in Rouen. So this is the Place du Vieux Marché, where you have the Rouen barbecue, where she was burnt. This is what you can see on this painting. So one of the historical things to see in Rouen is the history of Joan of the Arc. And if you go a bit outside, on the outskirts of Rouen, you can go to Giverny. If I stay on the Claude Monet paintings, this is a very famous painting of Claude Monet. Giverny is a city between Rouen and Paris on the River Seine, where you can see beautiful gardens. Really, I would highly recommend you to go there also, especially in spring or in the autumn. There's a bit less people as in the summer, and this is the garden where he painted this beautiful Japanese bridge. And another place next to Rouen is Étretat. Where you can see these very typical sceneries of the English Channel scenery, and this was also painted by our dear Claude Monet, one of the Impressionist painters who was remarkable in the history of Rouen and of Normandy. So I hope these pictures gave you some interest to our beautiful city and region, and I know some of you have already come there, especially Gunnar, so you, I suppose, would also be quite a good advocate for this region.
So thanks so much. And this was a very interesting talk. Thanks for sharing your experiences in this field. Dominique, we will meet next week again, and we will be in Caen next week. So have a good night. Thank you.
Cheers.